Good evening, everyone. My name is Michelle. I'm a product specialist here at Oculus. Welcome to tonight's clinical webcast, Key Elements of Pentacam AXL for Myopia Management. You have a text box where you can enter questions. Feel free to enter your questions at any time, and we will discuss them at the end of tonight's webcast. Our speaker tonight is Dr. Kevin Chan. Dr. Kevin Chan earned his Bachelor of Science in Pharmacology from Western University in London, Ontario, Canada, and his dual OD and MS degrees from New England College of Optometry, Boston, Massachusetts. He is the Senior Clinical Director of Treehouse Eyes, the first and only specialty eye care company spanned across the United States that dedicates exclusively to providing myopia management for children. Dr. Chan is a fellow of the American Academy of Optometry. He is in the ESSLER's Myopia Task Force, leading the initiatives of myopia education and awareness. He was an invited panelist to partake in the inaugural Ophthalmology Innovation Summit Myopia Showcase in 2021. He starred in the renowned TEDx talk titled Myopia Global Epidemic in 2019. He frequently lectures in the field of orthokeratology and myopia management locally and nationally. He is awarded the Best Optometrist by the Washington Parents Magazine in 2020. We are excited to have Dr. Chan with us tonight and look forward to your presentation.
Hi, everyone. Thank you, Michelle, for the kind introduction. My name is Kevin Chan. And tonight, it's my pleasure and honor to be able to spend an hour evening with you guys, and thanks for joining us tonight. And today my talk is going to be about the implementation of OCULUS Pentacam AXL, specifically for myopia management. So hopefully, by the end of the section, you will be able to bring something to your practice and be able to implement it and serve more patients in need. I have no financial disclosure relevant for this presentation. To start off, I think myopia is nothing new to us, and we all do this every single day. It's like our daily bread and butter. But historically, we also look at myopia in a different perspective because it actually can be traced back in the age of Renaissance. And what you're looking at here is the Da Vinci's painting and the manuscript, showing that at that time, he's already been looking into the idea of contact lenses and something to do with the eyeball. So even though, of course, he may not realize, what he's studying and how the eyeball is going to evolve over time. But interestingly, we have been seeing that, we're using the same methodology that had been adopted for the past 700 years. Nothing has changed until recently. And the reason is that, and also unfortunately, we're seeing more and more patients are having myopia, and the progression is just changing so much dramatically. And as probably many of you have heard, myopia has become one of the leading causes of blindness, and it become a global epidemic. And at least according to the Brian Holden Vision Institute, they have done a study back in 2016. And the result have found that by the year of 2050, almost 5 billion people worldwide will become nearsighted. And chances are those 5 billion people, 1 billion of which will eventually become highly myopic. So that is a serious concern for our children and our next generation. When you look at the global prevalence of myopia, chances are you'll hear about a lot of something from China, Taiwan, Singapore. Interestingly, to my surprise, Singapore is actually one of the leading myopic capital of the world. And in fact, studies have found that over 90% of the population in Singapore has been suffering from myopia. And that is a serious concern, especially you see a lot of patients of Asian descent. Those are the patients that are truly in need of our myopia care service. Let's talk a little bit about how we can perceive myopia and what kind of paradigm shift we are actually looking in recently. And according to the International Myopia Institute, they have published a white paper back in 2019, and recently they also launched another white paper, second edition, in 2021. And they commonly identify myopia as a global threat to children's eye health. And when we try to challenge the understanding of myopia, we typically thought about myopia as only a refractive error, and it's nothing to do with how it evolves and changes the overall physiology of the eye. But more and more research have found that myopia actually represents the abnormal physiological disturbance to the equilibrium, to the overall ocular development. So the way we treat myopia need to be up to date. And the term myopia management or myopia control is the way to manage abnormal eye growth in order to mitigate lifelong ocular complication, so that patient would have a healthier eye in the long run, 10 to 20 years down the road. And here's comes in the white paper that I just mentioned earlier. And they found that every diopter matters. You know, when you can mitigate myopia, every diopter counts. In fact, a study by Bullimore and Brennan recently have found that for every diopter decrease of we're able to slow down the risk of visual impairment by up to 40%. And fortunately, more and more research have been available recently that those evidence suggest we can prevent and delay the onset of myopia. So as a clinician and practitioner, we definitely have the more obligation to do our best in order to serve our patient with myopia need. So here's the histological comparison showing what an ametropic eye versus a myopic eye look like. So when you look at the physiology, there's a lot of sequelae associated with axial elongation, particularly RPE disruption, also with scleral lens, scleral thinning, as well as the extracellular matrix remodeling. And also you will anticipate some sort of posterior ectasia of the sclera in the long run. There have been a strong association between axial length and the onset of myopic maculopathy. And what we're seeing here in the graph is suggesting that it is a nonlinear or sigmoidal relationship between axial length and the development of myopic maculopathy. And the take home here is that when we look at the arrow shown in red, what we're seeing here is that the inflection point for change is the level of 26 millimeter. What it means is at the level of 26 millimeter, the rate of increasing risk of myopic maculopathy will be significantly higher in an exponential fashion. So studies have found that especially for myopic maculopathy, this is one of the leading causes of visual impairment. And in fact, Bullimore and Brennan published another abstract in the Academy of Optometry recently. What they found was for every millimeter of axial length elongation, it has been associated with almost 54% of risk of visual impairment. And to put it in practical term, for every millimeter of changes in axial length, the impact associated with all sorts of ocular health issue is almost 4 times as much as someone who is aging by just a year. And if we're able to slow down or reduce the axial length growth by just 1 millimeter, we're able to slow down and prevent almost nearly 1 year of visual impairment. So that is pretty significant, for our patient. So as we look at the overall understanding about, the conundrum between refractive error versus ocular length, there's still a lot of controversy and healthy discussion in our industry. Whether myopia is truly just a refractive error or simply associated more with the physiological abnormality. As I have alluded earlier, it's more to do with the physiological imbalance, or homeostasis is just a little off the balance. On the other hand, if you were able to practice myopia management by understanding refractive error, it's nothing bad about it, but you just have to know how to use it. So the BHVI recently have found out that there's a little schematic diagram helping practitioners to understand how we can use this terminology a little bit better. So essentially, refractive error could be a diagnostic tool for us to understand how the eye changes in diopter, but it lacked the sensitivity to discriminate structural variation of the eye. And in order to quantify how refractive error changes, we typically recommend practitioners to use cycloplegic refraction as the objective measure. If you don't do it, probably there's a lot of variation and the result can be skewed. On the other hand, if you were able to implement some sort of measure to measure axial length and quantify ocular health, then you're able to be able to make the data more reproducible and also more accurate. But this definitely would have a really good benefit for showing more sensitivity in order to track the treatment progress. But keep it in mind, ocular health and ocular changes can be associated with diurnal variation. More and more studies have found that the circadian rhythm and also the level of melatonin in our body can be associated or even directly affect the how the eyes evolve over time. So therefore, axial length can be changed from day to night. Let's dive into a little about how we can use OCULUS Pentacam AXL in order to be able to help your patient in order to serve the need. To understand this equipment, we need to understand the basics first. This Pentacam AXL is a non-contact anterior segment tomography with a 3D shine fluid imaging. And this allows precise data capture for the entire segment in just a matter of seconds. Particularly, there's a number of different models of Pentacam. AXL is actually one of the few, and which specifically able to integrate axial length features in order to aid accurate IOL calculation as well as myopia management. For this presentation, I'll only focus on this particular model. Here, just a little exhaustive, comprehensive highlight about what the OCULUS Pentacam AXL can do for our clinic. And for the sake of our clinic, we typically just use a number of clinical features in the equipment. But for those patients, for those practitioners who are doing primary care, doing a lot of diagnosis for keratoconus and pre and post-op cataract care, definitely this is the machine that you want to consider having. Let's look a little into the idea of shine fluid imaging. Probably, many of you may not realize the complexity of how this machine works. I'm not an engineer, so I would just know the basics of how it works. Essentially, this imaging technique is by using the rotating camera in order to capture the corneal cross-sectional slide that is illuminated by slit beam at all different angles. And it makes use of the extended depth of focus without changing the aperture size. And you can take up to 50 cross-sectional images, in 180 degrees, just in a single scan. But usually for our patient base, because we're dealing with solely pediatric population, chances are the kids will not sit still for us. So we typically will use about 25 cross-sectional images in a single scan. Later on, you'll see a little bit more schematic representation of what it looked like. Here they are. After I take the single imaging shot, we're able to see all different anterior segments. After we imaging the patient, we're able to capture all these data and composite into a 3D model. The tomography were able to help us understand from inside out, and this is also a really good educational tool for parent and patient to understand. This is our eye from the cornea to the lens, so that will actually able to help us appreciate how the axial length evolve over time. Sometimes I can even demonstrate to patient your eye is physically getting longer, so physiologically it's not really healthy to have a football shape in your eye. After taking the image, this is the overview showing what we can achieve from this overview slide. Just going through from a clockwise approach: keratometry, pupil size, HVID, axial length. Obviously, it's one of our topic of interest tonight, and also the dosimetry. This is the way to represent the corneal clarity. typically, you're not just taking the image, you also want to make the image to be in quality, good quality. So typically we're aiming for the corneal clarity in the Pentacam to be less than 30. And that is considered normal. Anything higher than 30 will be considered somewhat at the borderline, or the image will turn out to not be able to interpret. Here, you're able to make some changes and be able to tailor how you want to analyze the data. So for example, this snapshot represents the 4-map selectable, showing you the cornea in a different perspective, ranging from axial map, tangential map, pachymetry, as well as elevation map. So just to briefly touch upon what each map does, axial map is to represent the overall comparison in dioptric power, whereas tangential map is to demonstrate how the curvature evolves, in different areas of the cornea. And obviously, pachymetry is to measure the corneal thickness, as well as the elevation map is to measure the highest and lowest point on all the cornea in order to measure the overall sagittal depth. Later on, we'll talk about this subject a little bit more in detail. So here we are seeing that the kids, once they finish up the single capture, we're able to demonstrate to them that this is the long eye. Consider long eye because the axial length is about 24.7 millimeter in size. And when you look at the signal to noise ratio, also known as SNR, it's over 200. What it means is, when you have an SNR greater than 100, typically it represents the picture was taken really reliably with a lot of reproducibility. So as you can see at the bottom, there's a seismic wave pattern showing that where's the peak of the signal being generated. So this is what you're looking for. Whenever you have a technician to help you out, taking this picture, make sure you let them know how to take a picture reliably. And I want to touch upon a little bit about a different technique so that you have a good comparison, because a lot of clinicians and practitioners ask me about between A-scan versus other optical biometry to help out with myopia management. So A-scan is considered something, making use of the reflection of high-frequency ultrasound wave through a medium. However, the ultrasound wave does not travel through air. And the frequency being used is usually ranging from 2.5 megahertz to 20 megahertz. And usually the signal is proportional to the resolution, but not the depth of penetration. So for instance, if you were to use A-scan for someone who are having dense cataract, chances are the resolution will be pretty poor. But for our population dealing with kids, typically, the eyes have no opacity or anything that is blocking the view. So the depth of penetration is actually pretty good with A-scan. But obviously, there's a downside, and I wouldn't consider a downside, but some consideration that clinicians need to be aware of. So first of all, A-scan require topical anesthesia for a young kid. It's not something that easily being done just because the kid is not be able to sit still for you, and let alone is just having a probe touching the eye. The thought of this has already been pretty challenging and intimidating for some kids. So having local anesthesia topically is not the most preferable way for kids. Second of all, it's about the direct contact to the cornea. And sometimes even adult may be having a hard time to deal with this. And also we have to deal with the challenge of having fixation and apprehension issue. And also it's just something not reproducible. And the data would turn out to be so over places and it could be skewed very easily. So typically I recommend A-scan only for someone who are want to get a feet wet in this field of myopia management, but not sure which instrument or machinery need to buy, and something you want to start up, but it shouldn't be your long-term equipment for measuring axial length. In contrary, when you look at other optical biometry, specifically this Pentacam AXL imaging, I have a lot of experience dealing with this equipment in the past few years. And the greatest advantage is that it's greatly reproducible and it's highly accurate. And it also doesn't require any direct contact for the patient, especially during and after COVID. Patient will be more cognizant about anything with direct contact. So you want to try our best to do something that can still achieve the good result without any direct contact with the eyes. And more importantly, many instruments that I have dealt with is sometimes the tear film can be one of the contributing factor for poor imaging quality. So for this Pentacam AXL is independent to tear film. So you're able to capture the image regardless of how the tear look like on patient size. And obviously, when you combine all these things together, the experience is pretty user-friendly, even for a young kid. But some consideration is that, for clinician having multiple office, satellite office, sometimes it may not be easy to transport the instrument back and forth. So it could also be a long-term investment for a clinician to consider, but it's definitely worthwhile for doing so if you want to be serious about treating myopia in a good way. This picture was taken pre-COVID, so I have a pleasure and having some luck as well to deal with this 6-year-old patient, and he has been very tame and very, very good with taking this picture. So for clinicians who are considering some sort of optical biometry but not quite sure whether it's doable for kids, my answer for you is yes, but it definitely takes some experience and learning curve for you to know how to deal with young population like this. In terms of taking good quality of image, I think this is just something I learned from mistakes and tons of repetition. And sometimes I found that a lot of clinicians taking pictures but with a really poor quality, so eventually it's not being able to interpret the data reliably. So the way here I'm showing you is that the top half of the image is to show you what the ideal capture look like. So essentially you want to make sure the patients open the eye with full aperture in order to capture the full size of the cornea. And because having a full HVID will also be able to affect the direct cord length that you're going to measure for, let's say, if you're dealing with someone with Ortho-K design, cord length is one of the key factor. If you have, something like the bottom half, okay, the bottom image suggests that you only have, 3/4 of the view, you can look at and be able to interpret the result. Chances are the cord length and the result will be highly skewed. So just be aware of how you want to instruct your technician or even yourself how to take good quality of image from the Pentacam AXL. Here's the first case I want to share with you. Here's a 10-year-old African male being referred by his ECP for the initial consultation for myopia management. And at that time, his habitual RX is about 425 and 475. And the VA was about 2025 and 2040. And at that time, we are able to capture the axial length by the Pentacam AXL. His axial length is actually pretty significant at his age, about 24.7 on the right eye and 24.9 on the left eye. And this patient is pretty athletic, doing Taekwondo almost every single day. So upon a lot of discussion and education with the patient and the parent, we decided to move forward with the idea of using orthokeratology lenses. Later on, we'll talk about specifically what is the determining factor for designing custom Ortho-K lenses for patient using this equipment. So let's take a look at his baseline profile. You have looked at this slide earlier, showing what the 4 refractive map look like. So specifically, we're seeing that in the axial map here, this patient have shown us a relatively steep apical cornea. And that tells me that the dioptric power suggests it's been almost by 46 diopter. This has been considered not the highest, but relatively high to consider something to be more customized. And just want to give you a brief overview for those who are not familiar with the idea of touricity. We typically describe cornea in the lingo of corneal touricity. not the astigmatism. The reason is that there's a different type of touricity we're dealing with. Sometimes you're seeing patient with, the picture shown on the left, kind of like apical, being more concentrated within the pupillar margin, whereas you have other patients dealing with a lot of limbal to limbal touricity, and they can also be oblique cylinder. So that is something that you'll be aware of, what kind of corneal map you're dealing with. And depends on which map you're dealing with, the way you approach the design of Ortho-K can also be highly varied. One of the best way to quantify touricity is by using the idea of sagittal height differential. And again, I want to illustrate the point here is, when you look at this picture, assuming this data for you, so we're actually looking at different sagittal height at different cord length. For example, you're seeing that, the measurement was moving from 6 millimeter, 7 millimeter, all the way to 12 millimeter wide. And that is to show you the extent of how much we can measure, but typically we want to capture the sagittal height differential at the cord length of 8 millimeter in size. That would generate enough measurement and also the information that we need to generate the Ortho-K lens. Here's the study done by Pat Caroline from Pacific University. They have done a pilot study showing the actual differences between corneal versus refractive astigmatism by age. And the purpose of this study is to find out, is there any difference between the refractive astigmatism versus the corneal touricity based on the patient's age. What they found was patient under 16 years old, chances are you'll see a lot of differences between refractive astigmatism versus corneal touricity by up to 3/4 diopter. And that's considered significant when it comes to the Ortho-K design. But as time goes by, as patient is getting older, chances are they would be able to normalize the overall differences. You can see by the time they're at mid-age, mid-30 or 40, the differences between these two parameters is down to 0.38 to 0.29. So this leads to the next point. How can we make good use of sagittal height differential in order to help us quantify the design of Ortho-K lens? What I like about using Pentacam AXL is by using this sagittal height calculator. And here we're seeing the horizontal and vertical meridians, and each meridian generates a different height measured by micron. And you can see that the flat and steep meridian had a difference of almost by 44 micron in size. So that is considered pretty significant for someone having just a low refractive astigmatism. So that reiterates the point that you cannot equate the changes between corneal astigmatism versus corneal touricity. So because of the high sagittal height differential, we decide to make good use of the toric design using this calculator. So fast forward 6 months later, patient has been doing really well. The imaging shown on the right-hand side is the baseline topography. The one shown on the left-hand side is the 6 months follow-up topography. And patient after 6 months later, seeing 20/20 in each eye. Perfect topography here. Fast forward 2 years later, I did an annual follow-up for this patient. This is not surprising to us that patient is still growing physically. He's undergoing puberty. So a lot of time you will see some changes or variation in axial length. Usually do not be too alarmed by that. For this particular patient, he has changed by about 0.11 millimeter per year. Versus for someone who are not being treated for myopia, chances are they will actually change by 0.25 to 0.3, which is about approximately 1 diopter in magnitude. Here's another example showing that what Pentacam can do for you in terms of providing the wow factor for patient. What we're seeing here is a 6 months comparison in terms of the way from baseline shown in the middle versus 6 months follow-up on the left-hand side. The image shown on the right-hand side is the overall comparison, And eventually, we're seeing that axial length changes literally by 0. So when I deliver this message to patient, this is really powerful for patient to understand your eye can literally freeze, in a certain time frame. But obviously, it's I consider as a serendipity opportunity. It's not something I see all the time, but it can definitely exist in certain patient if you're doing good quality control and be able to deliver the most effective treatment for myopia. Then patient would definitely be wowed by your results. Here, I just want to touch upon, for some clinicians who are familiar with the idea of WAVE custom contact lens software, you can actually incorporate this WAVE software with Pentacam. And for those patients who are showing a lot of complexity on the cornea, and you're not sure which lab you want to deal with, most of the time I recommend clinicians to consider having a custom design using WAVE software, and it's highly customizable from every single quadrant to even every single meridian. And when it comes to analyzing the idea of soft multifocal lenses for myopia management, most of the time, clinician were just leaning towards the refractive changes or whether, it's doing well in the slit lamp. But just be aware, there's another added component in the Pentacam imaging technique. You're able to showcase how the soft lens does on the patient's cornea. So in this example, patient is using a custom toric multifocal lenses shown on the left. The one shown on the right is the baseline image. And what this illustrates is that patient can sometimes show a bit of axial misalignment. And sometimes because of the notion of angle kappa, and you're not able to perfectly align the geometric axis versus the pupillar axis. So sometimes there's a bit of misalignment. So be aware of how we can make good use of this imaging. Take the topography with the contact lens on and see how the lens actually sit and position on patient's eyes. And if the axis do misalign, you want to do something like what we call the decentration offset technique. So sometimes I usually does this, when we see a true misalignment, patient is complaining a lot of symptoms, including halo and glare, and especially for young adults who are starting to drive and they're having a lot of difficulty with night driving. So most of the time we look at the topography over the lenses and see if there's anything we can identify or detect. If there's truly some misalignment there, we'll talk to the lab about redesigning the lenses so that we can try to offset the position so that we can realign the geometric axis along with the pupillary axis. Here's another case, a bit challenging. Sometimes it may not be, a straightforward cases or deliver the result that you want. She's a 6-year-old Caucasian girl who failed vision screening. And according to mom, patient have failed the vision screening because the school nurse told us that patient may have nearsightedness, which is good news because the school nurse can actually detect myopia. And in terms of family history, patient has really strong family history. Both mom and dad are highly myopic, especially mom with the history of retinal detachment. At that time, patient wasn't wearing glasses. The entrance on VA was only about 20/70 in each eye. And obviously, 6-year-old doesn't know much about, her vision, and she's not really compliant with wearing glasses. So patient were pretty concerned. Parent doesn't know whether this condition is going to get worse without glasses or not. So at that time, we're fortunate enough to be able to measure her axial length at a level of 23.1 millimeter on the right eye, 23.03 on the left eye. So here's a schematic representation showing, what the shine flow imaging does for this patient. Her baseline on the right eye is about 1.25 with some refractive astigmatism. Left eye, pretty similar, but you can see that the axial length varies a little bit, right eye being slightly longer. So at that time, upon a lot of extensive education and discussion with the parent, we decided to move forward with the combination approach by using Ortho-K lenses along with atropine drops at 0.02% as a combined treatment approach. Because we understand that this patient may not be complying with glasses, even if we start having atropine drops for patient as a treatment approach. Atropine itself would not be able to correct the vision, so we definitely need to have good vision for this patient. So Ortho-K will be a really good choice for parent and also for patient to understand we can actually help them to see a lot better unaided during daytime. I like to use the features in the Pentacam AXL to quantify how the pupil respond to certain treatment approach. For example, this patient undergoes the combined treatment, including atropine. Typically, we want to measure the pupillary size pre and post treatment and see how much change we have. So upon 8 weeks of follow-up, this patient have not changed that much and just about 0.12 millimeter in size differences. So believe it or not, most kids are actually pretty adaptable and they can accommodate a lot better, easier compared to adults. If you were to treat adult with atropine drop with this type of pupillary size difference, your young adult patient may not be very happy with you because they have a lot of symptoms of glare and halo when they're driving at night. And the distant center vision may also be somewhat affected because of the dilated pupil. And when I look at this patient after a year or so, we can see that there's definitely some differences between the baseline and the annual results for the axial length measurement. It changes by almost 0.68 millimeter in size, which is approximately equivalent to about over 1 diopter change in just a year, despite the fact that she's been undergoing combined treatment. Similarly, for the left eye, 0.7 millimeter in size. So what did we do wrong here? Well, I consider nothing has been done wrong. It's just a matter of sometimes patient may not be fully compliant with the treatment that we recommended. In fact, this patient, the parent later told me that patient has not been fully compliant with either treatment approach. Sometimes she would start having Ortho-K for 3 times a week, and then switch to atropine 3 times a week, back and forth. So that would definitely skew the result, in the long run. So definitely compliance and motivation is the key for success in myopia management. After this result, we're able to do some more calculation, and later on we decide to bump up the atropine concentration from 0.02% to 0.05%, still at the same regimen, 1 drop at that time, OU. And after 6 weeks or so with this regimen, we're able to see some improvement in the axial length here. In fact, not even an improvement. In fact, the axial length have shown some small reduction in size. Later on, we have another case here. When we deal with patient coming in as a sibling, even as identical twins, there's always been fascinating to see the results. So here's a 13-year-old Asian female siblings. They're identical twins. They start wearing glasses at 7 years old, and their progression, according to mom, is about 1 diopter per year. Strong family history, especially mom is highly myopic. I think it's about -9 to -10 diopter. And at that time, she was referred by her ECP. Let's look at the older and younger siblings. And I just want to highlight the fact that the axial length measurement actually looks pretty comparable between these 2 siblings. But one is more motivated and more active in lifestyle, whereas the other one is more like a bookworm. She just like reading, but not going outside. So upon a lot of discussion and education, we decided to customize the treatment approach for each siblings. And we want to monitor her periodically. Right now, we have been seeing those siblings for about 2 years now. Here's the result. What we're seeing here is the growth status, in a function of cumulative axial length in millimeters shown on the y-axis. And the x-axis shows the actual periodic change over time from 2 years ago up till April this year. So the top two line graph suggests, how the younger sibling has been doing with Ortho-K lenses, whereas the older siblings at the bottom two line graph showing that there's a little overlapping crisscrossing pattern between the baseline and the first year, which is kind of interesting. Later on, we'll see another analysis showing, what exactly is changing. Here's another picture showing that what we're using is the variable of variation of axial length by millimeter. We're actually quantifying how much physical differences we're seeing in different time frame. As you can see, the bar graph showing that, with the exception of the one in red showing, on top of the x-axis, all other bar graphs shows as a downward trend. This indicates the axial length actually continuously going backward or regressing. So this is out of our surprise, because we typically want to, just to deliver the realistic outcome is to slow down myopia by stabilizing the axial length. But sometimes you never know when patients are really responding to the treatment compared to the previous case. These two cases are really, really wonderful to see that patients are really responding to treatment even beyond our expectation. So we can deliver above and beyond. So at the end of the second year, both siblings have shown us with a reduction of about 0.3 millimeter changes in reduction, which is about the same as about 1 diopter better compared to the baseline refractive error. So what did we learn from this case? Axial length can actually be regressing. And this regression is not just a sporadic event, but can also be cumulative and long-lasting. As you can see, it doesn't just happen for the first 6 months. It continuously happens upon the first and second year as well. And this trend observed is not just about one specific treatment, but both orthokeratology lenses and also soft multifocal lenses modalities. And a number of researchers found that this phenomenon can be attributed by the fact, some sort of myopic defocus theory in combination with choroidal thickening effect. So we don't know which one comes first or which one is the chicken and egg effect, but what we know is if you do it right, the equipment and technology and all the methodology that you're using can actually help slow down axial length dramatically. So let me just recap. Myopia management is not just about what you do or what kind of steps you're taking. It's actually going to represent the paradigm shift, how to view myopia and how you want to plan out the strategic action in order to do it proactively. And if you were able to incorporate axial length measurement in your strategy, it will even be a game changer for your patient. Specifically, I have been having a lot of great success with the Pentacam AXL. By using this, we're able to tailor and customize the treatment approach in order to guide our decision-making process. So really, if you want to get serious about myopia management, really do think about incorporating axial length as one of the go-to parameters that would save you a lot of unwanted visits. So here we just want to briefly introduce you, what treehouse size look like. Our base is actually at Washington, D.C. metropolitan area, and we have been doing myopia management specifically for children for the past 5 years. And it's been a lot of great success, and we also have expanded nationwide. For practitioners who want to learn more about, how we can work together and partner with treehouse size, feel free to email me and contact us. We'll be happy to provide you more information. So I think we have a couple minutes for questions. I'll pass it on back to Michelle.
All right. Thank you, Dr. Chan, for that great presentation. And I just wanted to remind everyone on your GoToWebinar screen, there is a text box where you can enter any questions you may have. If you missed part of the webinar, or if there's anything you would like to go back and review, you will receive a link with the recording in the next link. And we do have quite a few questions, so I'll go ahead and just get started on that. Do you always start with Ortho-K treatment, or do you ever use other methods from the onset?
Yeah, that's a good question. As we all know, there's a different modality for treating myopia. Ortho-K has comprised almost 60% case in our clinic, just because patients are more willing to see the big difference with Ortho-K. Not to, just to discredit other treatment modality, soft contact lenses as well as atropine drop is really effective to slow down myopia. So, but Ortho-K does have a wow effect when patients come in for the first day follow-up. We typically want to let them be aware of what the difference it makes, before and after. A lot of patients were so surprised and astonished about, how well they can see, even just upon first day of treatment with Ortho-K lenses. Most of the time they can see 20, 30, or even better upon day one. So by using Ortho-K lenses, we're not trying to, which side we want to take or which modality we prefer more. It's more to do with what the clinical data suggests at the baseline.
Okay, thank you for that. Okay, you had stated that the time of day could affect the axial length. Do you have a preferred time of day that you schedule your baseline examinations to get the most optimum axial length?
Yeah, so that's a really good question. And honestly, the answer is still unknown because you still see some research showing that, diurnal variation actually matters and more at nighttime. So the variation obviously cannot be measured when patient goes home and before bedtime. That's not possible. But what we usually do in our clinic is to measure the axial length in the morning in order to capture the most, or at least most approximate finding according to some research. Mm-hmm.
Okay. And do you find that myopia control patients usually continue to wear their Ortho-K contacts into adulthood?
Yeah, so that's another important message that many patients ask me about. How long does it take, for the kid to undergo myopia treatment specifically for Ortho-K lenses? My answer is for as long as you want, or for as long as you can, just because the kid can still have a chance to progress even in the young adulthood. I have seen patients who have grown even at the mid-20 level. So it's not surprising for them to see some changes when they go to college, especially if they have a lot of knee work associated with the lack of outdoor time. So chances are patient will still be needing some sort of myopia treatment even when they're young adults. But the modality could be somewhat varied, depends on their lifestyle. If patients are having some sort of symptoms with Ortho-K because they have a longer day to go by and they cannot really function well with some receding vision, sometimes you may need to help them out by using soft contact lenses at nighttime in order to make them more functional. But as time goes by, it all varies from case to case basis. But to answer the question, chances are you'll most likely need to educate the patient. Myopia treatment need to take place for as long as it does need to happen.
Okay, thank you. What do you consider different stages of severity of myopia, and do you have different treatment plans of these patients?
So the question is, how do I quantify the stage of severity of myopia? Is that correct?
Yes.
Okay. Usually, according to the white paper published by the IMI, they quantify high myopia as someone who are higher than -5 diopter. Anything less than -5 is considered mild to moderate. But again, it's just a more standardized way to classify myopia. Sometimes, when patient coming in, at 6 to 7 years old, presenting with a 3 diopter in refractive error, I consider those patients at high risk. So I think my advice here is do not be limited by just the refractive error alone, because like what I said earlier, the whole point of this presentation is to illustrate the importance of why axial length matters more than just the refractive error alone. The refractive power help you diagnose myopia, but it's the axial length measurement that could help you guide the treatment progress and how you can customize the treatment approach for a patient. So that is my advice for practitioner.
Thank you.
Mm-hmm.
What is the minimum investment in equipment or training to begin a myopia control practice?
That's a good question. I think we need to have another separate talk or even a different webinar to deliver this data. But I think in general, you're talking about in order to invest into something that is kind of like axial length measurement or some sort of optical biometry, you definitely need to, spend investment on it. But other than that, you also need to provide enough resources and staff training, to be able to deliver the reliable results. Because you yourself cannot do it on your own, but you need to provide more education, and those education would be, being done by your staff. And education for your staff is also key for this process to be successful.
Okay.
But definitely feel free to email me. We'll definitely, talk more about the strategy and also the logistic, how you want to approach it.
Okay, great, thank you. What are your recommendations when taking scans with the Pentacam AXL on fidgety children? Do you have any recommendations?
Yeah, so that is my daily struggle as well. But I'm doing better just because like what I said earlier, a patient at 6-year-old sits still, whereas a 15-year-old can be fidgety. So age may not matter in this case. But I think little tips is that, patient wants to have some expectation what they're looking for. When they actually look at the Pentacam, what they're trying to do is to fixate at a target. What I tell them is look at the red light, blink a few times before you start to do a fixation. For a young kid, we typically don't use the lingo like fixation or target. We typically just still, talk about staring contest. If you want to outbeat the computer, you want to stare at the light for as long as you can in order to capture the image. So I think, parent can also play a role in terms of how they stabilize the posture and everything. And everyone come into play when it comes to taking quality image. So there's no set formula, but I think, try to set a good expectation for patient would be helpful.
Okay, great. And do you ever receive patient referrals from pediatricians, or do you only work with eye care providers?
Yeah, so our clinic is referral based, so we typically have a lot of referral from, most of the time ECP, they're ODs, but they're also referral from pediatric ophthalmologists who are not dealing with contact lenses or anything regarding Ortho-K lenses. There are also a small portion of provider who are pediatrician, who are cognizant about myopia and the importance of treating myopia. But I understand there's still some underestimation, how much they understand myopia. Most of the time, pediatricians were trained to do vision screening in their own office, but they don't really exactly know what they're looking for. So most of the time, we have to provide education to the pediatrician and also their staff member in order to make sure they understand what they're screening the patient for. Otherwise, a lot of time, they screen the patient, refer the patient, end up being hyperopic because they have a lot of skewed results. So, but the answer is yes, I have received a lot of information and referral from all different providers and different multiple discipline in medicine.
Perfect, thank you. And you had talked about combining atropine with Ortho-K. Do you do any other combos of treatments for myopia management?
Yes, we do. Ortho-K combined with atropine is one of the treatment approach, but we can also consider if the patient is eligible for soft multifocal lenses in combination with atropine as well. And at least in US alone, we can only do these 3 modalities. Other countries are starting to incorporate more like dim lens. There are the spectacle that can deliver myopic defocus that can also slow down myopia. But unfortunately, at this moment, US have not, the FDA have not shown the approval for this type of spectacle yet. So I think we're still waiting for the final stamp from the FDA in order to expand our toolkit.
Okay. Well, Thank you, Dr. Chan, for that great presentation. That is all the time we have for tonight, and thank you for everyone who sent in questions, and thanks everyone for joining us, and thank you so much, Dr. Chan.
Thank you. Thanks for having me. Thanks for everyone for joining it.
Yeah, and this concludes the presentation. On behalf of Oculus, have a good night, everyone.
Good night.